Dumelang Bakaitsu, Dumelang, hello everyone, Sanbonani, Molweni, and welcome to this discussion about the possibility of making COVID-19 vaccinations mandatory for staff and students at the University of Cape Town. I want to start by saying 4 things. First, the final decision on such a policy can only be made by the UCT Council. The executive will table this matter at Council at its next meeting this Saturday on the 16th of October. And second, let me say upfront that the UCT executive supports the idea of such a policy. The speakers we have invited to address you today will explain the strong reasons from a public health and occupational safety perspective for making vaccinations mandatory. Thirdly, we are hosting these discussions. We held a discussion yesterday with staff, and today we are having this discussion with you as students, because we know that making vaccination mandatory is a controversial subject. This is the time for you to register your arguments, both for and against the proposed policy. My hope is that you will raise a point that we have not yet considered, so that we can give it careful thought. Please write your comments and questions in the chat function. You can write under your name or anonymously, so please don't be scared. If you don't want anyone to know that it is you who's making the comment, you can choose to be anonymous in your comments, and we will take all those comments into consideration. Finally, you are also invited to complete a very short survey to express your views on a proposed policy. The link is posted in the meeting chat, and you can click on it and go to the survey, and the survey will close on Thursday, 14th October at 6 p.m. So please make sure that you complete that survey and invite your friends also to complete the survey. After taking into consideration the views that have been submitted, the executive will form a final position on the matter that will be tabled at Council. So we will compile the document that we present to Council, considering all the inputs that have been made. Our 2 speakers for this morning session are and first is Dr. Shital Kasim, and she is a senior research officer at the Desmond Tutu Health Foundation, and she participated in a recent vaccination study of a candidate oral antiviral medicine for COVID-19. And the second is Dr. Itumeleng Ntatamala of the Division of Occupational Medicine at UCT. His specialty is the relationship between work and health, and both of them will take us through the debates, and then we can have a conversation afterwards. So if you have a question, please write it in the question and answer bubble there, and we will take the questions at the end. We've got a panel that I will introduce at the end of the presentations, who will also help in engaging on the questions, concerns, and comments that you have to make. Over to you, Shital.
Thank you. Thank you for the opportunity to present this morning. So the slides I'm going to present may seem a bit technical, but I just want to highlight that there's an enormous depth and breadth of scientific and information and experience that we do have that underpins vaccination and the role of vaccination with this pandemic. So the pandemic has really changed the world. It has caused all of us and the world to be pushed out of our comfort zones, and we were suddenly forced into and now have almost adapted to a new way of living. But this is not new to us. We've been here before with the Spanish flu pandemic of 1918, and similar to COVID-19, it hit the world in a devastating way. And what I wanted to highlight with this slide is that an estimated 50 million people died during the Spanish flu pandemic, and most of them were young and middle-aged. Because we were a population that had never seen this virus before, when the pandemic hit, we were immunologically naive. Our immune systems have never encountered a virus like this. So in a non-immune world, we rely heavily on non-pharmaceutical interventions. And these social distancing, hand washing, physical spacing, wearing our masks, and also lockdown restrictions and closure of institutions like UCT. And the pandemic has really had a significant impact in our country. We are in a crisis. From the beginning of the pandemic, so around May 2020, already we have 250,000 more lives lost nationally from natural causes than we would have expected. And in 2021, that number is already 50% more than we expected. And a significant number of these deaths are under 60, people under 60 years old. So what I wanted to show with this slide is that this slide nicely shows the waves of COVID-19 that we've been through. We talk about waves a lot, and I'll explain the waves now. And also it highlights the lockdown levels that we had, so the restrictions that we had in place before, during, and after the different waves. Our first wave was, we were hit by the ancestral strain of the virus, so the original SARS-CoV-2 from Wuhan, the original virus. And we had lockdown restrictions. We had a level 5 and level 4 lockdown restriction that helped our health system prepare for the wave that we knew was going to come. The second wave was driven by the beta variant. So things that cause waves are the emergence of new variants, and then also pandemic fatigue. So getting a bit tired of our non-pharmaceutical interventions, like our spacing and our mask wearing. And another thing that contributes is slow vaccine rollout, uptake, and or access to vaccinations. And then you can see there in the slide that the third wave was largely driven by the Delta variant, and that's what we've just come out of now. I wanted to show this slide because we know that people with comorbidities or other illnesses are more at risk of dying from COVID-19, so more at risk from having severe disease. In our community, particularly TB and HIV and other non-communicable diseases like diabetes does put people more at risk of dying from COVID-19. So the way COVID-19 can affect us, we can get COVID-19 and be asymptomatic. We can have a mild infection, or it can cause severe disease and the need for intensive care and hospitalization. It can even cause death. As I've showed in the previous slide, there is a higher risk in older people and those with comorbidities. But recently with the Delta variant, we've seen young, fit, healthy people being hospitalized and even dying from COVID-19. Sometimes we don't really fully understand the reason why younger people and fit people would die from COVID-19. We do know that it has a higher tendency to cause clots when the disease is quite severe. And this has an impact on your lungs, your heart, your blood vessels, and other organs. It can cause long COVID-19. Long COVID is a disabling, debilitating chronic condition, and this we've seen has affected people of any age group. So this slide, because I wanted to show the different types of vaccines that are out there, and because of existing vaccine research, we were perfectly poised to rapidly develop and test COVID vaccines. There was a multinational effort to get a COVID-19 vaccine out, and we maximized efficiency in the way the clinical trials were done. There are different types of vaccinations. The ones I've highlighted in red, the Pfizer vaccine and the Janssen vaccine, the J&J vaccine, are the two that we have available in South Africa. The J&J vaccine is a single dose and the Pfizer is a double dose vaccine. And what also is important is that all vaccines work towards the same goal of inducing immunity so that our immune system is no longer naive to SARS-CoV-2. Some of the benefits of a vaccination. We know that the vaccination can provide long-lasting protection. We don't know how long the protection is going to last, but we do see that up to 8 months, up to 12 months, we have immunity against COVID-19. South Africa is very well developed in terms of our existing vaccination programs, such as our childhood immunization program. So we have infrastructure that will enable us to deliver this vaccine effectively. And importantly, and I think importantly for most of us, we can overcome the social stigma, the behavior change, and the adherence to the non-pharmaceutical interventions. We're all getting fatigued. We're all getting tired of not seeing our friends and family, and we really want to hug again. So this vaccine will help us do this. Another thing, when we are faced with something new, 19, the first focus of a vaccination is protecting life and saving lives. So the primary goal of these vaccines is to save lives by preventing severe disease, hospitalization, and death. And you'll hear me say this a lot during the presentation. That was the primary goal of the vaccination program, including preventing people from dying and those who are most vulnerable and at risk. And then eventually there is a potential for community-wide immunity, and I'll speak about this later, but we have seen this in other vaccines, with other vaccines. Okay, so we all know about variants. When the virus mutates, and this is a natural process, especially with an RNA virus like SARS-CoV-2, the variants are labeled variants of concern, and these variants are maybe more transmissible and maybe can cause more severe disease. And we know the Beta variant and the Delta variant are the two variants that have driven the waves in South Africa. When we talk about vaccine escape and vaccine efficacy against these variants, the variants may cause the vaccine efficacy to take a bit of a knock. So maybe be less effective against protecting against infection. But what we've seen with the vaccines that we have is that these vaccines are still very effective in protecting against the variants of concern and specifically protecting against hospitalization, severe disease, and death. And this is what happened in January this year. We had a vaccine and we realized that it wasn't performing very well against the Beta variant, and we had to make another plan. So these two vaccines are approved by the World Health Organization, the Pfizer and the Johnson & Johnson vaccine. And this slide, I just wanted to highlight how it more than 85% efficacy against severe disease, even in the face of variants. This slide is just showing the variant. So the variant, the Beta variant that we've heard about, the yellow is showing the Beta variant, and that was mostly in the second wave. And then towards the end of the graph, there is a light green color. And if we move forward this graph 3 months, we would see that the green would be more predominant, and that's the Delta variant. So what about real world studies? We know that there's been phase 3 studies and clinical trials on the vaccine. And we have a lot of data and a lot of information that shows that in the real world, even against the variants, the vaccines do hold up very well. And I wanted to talk about this in an analogy. So we know elite sports people, Serena Williams, Sia Khaleesi, excellent sports people. They are elite athletes. Even if an elite athlete is not performing at their best, they're still pretty amazing, right? And like elite athletes, existing COVID-19 vaccines from such a high level of immune response to start with, that even a little knock or a little injury caused by variants won't completely reduce their efficacy. So these vaccines, like these athletes, are really difficult to beat. And some more real world data. The reason why I'm talking about Sisonke is because this is happening. This is what we have from our country, from South Africa. Sisonke was the healthcare worker program where we vaccinated close to 500,000 healthcare workers. And with this slide, you can see that we completed vaccinations just before the third wave. This was important because we got vaccinations done in time for healthcare workers to get back to work, to have less time off, and to look after us in the hospitals and the clinics. And the Sisonke program also gave us good real-world data. So you may think, what about the Delta variant, and what about the Beta variant? And I've got some slides to show that. But with this, the blue line is the vaccinated population, and the red line is the unvaccinated population. And we're still seeing 85% protection against death, and 65% protection against hospitalization. But remember, not all those who are hospitalized may have been in ICU or may have needed oxygen. And then the vaccine efficacy during Beta and during Delta, yes, it may have taken a knock, but it was still very good. So in summary of the vaccine performance, the phase 3 trials in which that were tested with the ancestral strain, the Wuhan strain, showed that all these vaccines have performed very well against early variants in terms of prevention of severe disease and death, and also against the Beta and the Delta variant. With all this data we're also collecting safety data, and we see that the vaccines are safe. Yes, we have heard about clots and inflammation around the heart, but these all sound scary, but in fact, the more millions of people we vaccinate, the more likely we are to detect these excessively rare and treatable conditions. And in this case, the benefit of vaccination far outweighs the risk, because it's not only an individual benefit. So the purpose of the COVID-19 vaccination, we want to keep the essential workforce going. We want healthcare workers to be able to function efficiently and serve our health system. We want to protect vulnerable and in general, the general population from severe disease and death. And eventually we would like to develop community-wide immunity. And this community-wide immunity only happens through vaccination and mass vaccination. This screenshot is really very illustrative of how well the vaccine can work. The red figures are those who are unvaccinated. And with this, we can see that this virus is really starting to affect more and more unvaccinated people. In other countries, like in the UK, where there's good vaccine coverage, we see that the cases, hospitalizations, and deaths have dropped dramatically after vaccination. Yes, it's in the older population, but also we will see a drop in the younger population as well. So what about natural immunity? Yes, okay, if we do get coronavirus and we get sick with COVID-19, we will develop some sort of natural immunity to the virus. So we will get some protection. And it is a really good thing if I get COVID and I survive the disease. But we must remember that repeated infections can occur, especially with the new variants that I spoke about. And what vaccination does for us, it just boosts our immune system. It really gives us a nice booster so that we are more protected. It increases the depth and the breadth of our immune response. And how does this affect community protection? So this is a very, very important slide. And this is something that we can think about when thinking about our UCT context. So in scenario A, there's poor vaccine coverage. Where there's poor vaccine coverage, the virus will find a gap. It will find a gap in our community immunity, and it will cause an outbreak. Whereas where there is good vaccination coverage, we know enough now that vaccinated people, individuals who are vaccinated, are less likely to get infected. If they do get infected, the disease is milder, it's shorter, so there's less time to actually transmit the virus. So with good vaccination coverage, that's what we're aiming for. We're aiming for a decreased viral load, a decreased amount of virus in our community, and therefore a decreased chance of spreading to people. And this is very important because not everybody can get vaccinated, maybe for medical issues or medical reasons, and we are wanting to protect those people by getting vaccinated if we can. Another analogy that is really illustrative of how a vaccine works. So if I get vaccinated, I'll build a hedge. I sort of build a little hedge around me. Of course, I can't build an entire hedge around my whole body. So the coronavirus may not get in. It can, though, there is a risk that it can still get in, but the more of us that are vaccinated, the less virus that can get in to us. If I'm the only one vaccinated, the viral load in the community is high, and then that virus can jump my hedge and I can get infected. But because I'm vaccinated, I'm less likely to die from coronavirus. And that's what we're aiming for. We're aiming for the community, a community hedge to prevent and to protect all of us. There is some light at the end of the tunnel. With comprehensive vaccination, we see in Denmark, yes, okay, we don't know how long this is going to last, but COVID restrictions have completely been lifted. And we're hoping for something similar in the future. So let's talk about UCT. What will comprehensive vaccination and mass vaccination do for us? It will reduce the force of infection on the UCT campus. It will reduce COVID-19 prevalence on campus, decrease the risk of severe disease and death in staff and students, and also reduce hospitalization and therefore time off from work and from school for illness and quarantining. and will also allow staff and students to return back to what we know is university life, return back to class, return back to lectures and tutorials, return back to our wards and our labs, some sense of normality. Mandating behaviors is not new. There are precedents for mandating behaviors. For example, seatbelts, protecting the wearer of the seatbelt, monitoring blood alcohol levels, protecting the person who's drinking and driving, the driver and the public, and also prohibiting smoking in public spaces for the benefit of people who may inhale secondary smoke. And then similarly, vaccine mandates are not new. Travel in yellow fever endemic areas, you are required to get your yellow fever vaccine every 5 years to control the spread of the virus and to protect yourself. Hepatitis B vaccination is routine for all healthcare workers and even medical students at UCT to protect yourself and the patient. And then mandatory vaccinations for children to prevent common childhood infections. By this, we've eradicated smallpox and we're very close to eradicating polio. So the take-home messages are that COVID-19 vaccines are safe and effective. And when they are taken to scale, they can allow a sense of normality and a return to, specifically in our little community of UCT, and even maybe in the future at a country level. It is the key to getting back to campus. And what's important is that any health behavior or health intervention always works better if being taken up voluntarily. And the hope is that after these information sessions, most people at UCT will take up the offer to get vaccinated. And UCT has actually made it very easy to get access to the vaccine through the vaccination center. But also important that those who have robust reasons to opt out should be heard and considered. I'm going to hand over to my colleague, Dr. Ntatamala.
Thanks, Dr. Cousins. Thanks, Sheetal, and good morning to everyone. Next slide, please. So I thought, emanating from Sheetal's discussion, let me put this picture here just to remind ourselves of what used to be the norm pre-2020. I've been here from 2012 as an undergrad and now postgrad, and it was the norm to walk across campus, socialize in the various cafeterias, and of course, even enjoy sporting events. Next slide, please. So COVID-19 has had a dramatic impact on the country, and I think for many of us young people living in this time, we probably will encounter this pandemic and learn quite a bit from it. We've experienced living under the Disaster Management Act, and of course those were instituted to limit viral spread. We've experienced 3 COVID-19 waves and numerous levels of lockdown and family meetings, as we have got to fondly know them as. And of course these have brought about limitations to our movement, limitations to gatherings as well. And of course they have disrupted political, social, and economic spheres of our lives as well. I don't only speak for myself, I think that many families have been affected by the loss of jobs, etc., because of the COVID-19 pandemic. And UCT as a community has also not been very different. We had to urgently enroll into emergency remote learning, and of course later on thankfully we're able to have a hybrid model where there are some on-site teaching opportunities and remote learning as well. However, it is undoubtedly clear that the COVID-19 pandemic has disrupted teaching and learning. It has also disrupted the sense of having a presence or an interaction between lecturers and students, whether be it in lecture halls or in practicals and tutorials as well. It has also, particularly for the many postgraduate students who are in the meeting as well, you may agree that it has also affected student research as well. Many research projects had to either be halted or delayed because of the pandemic or the restrictions that do not enable you to access labs, etc. on campus. And of course, I put a picture there of some of the Shoko events that we used to participate in as students, be it Shoko Health or Education, and other social responsiveness programs which have been adversely affected by the pandemic. And overall, the mental health impact has been severe for all of us. So what could the new normal be? And what would the role of COVID-19 vaccines be? As Shito has outlined, of course, if a large proportion of UCT is vaccinated, there is clear evidence that this will result in protection of not only students, but the wider community, including staff as well. And it could allow for a return to a much more normalized situation, which unfortunately at the current rate and with the current protective measures is unlikely to be reached as well. And of course, this has to be done according to a South African legislative framework. I see in the chat that there were links that were provided to some articles from the SA Human Rights Foundation, etc. And of course, these will also be discussed. Next slide, please. So what are some of the legislative prescripts or the legislative framework that UCT should be operating under as it considers a mandatory vaccination policy? First and foremost, as you know, the South African Constitution and the Bill of Rights would have to be respected. And they are very clear. Everybody has got a right to equality. You've got a right to freedom of conscience. You've got a right to religion, to your own beliefs and to your opinion. And this is part exactly of why this meeting is happening. One of the comments was, why do we even engage on issues around effectiveness of vaccines? Well, we already know. However, it is important that we allow a platform for everybody to air their views and to air their concerns as well. This is keeping in mind that the entrenched rights are not absolute, and I think that must be made quite clear as well, as it is outlined in the Constitution. The Constitution does allow for rights to be limited. However, the limitation has to be reasonable. It has to be justifiable based on human dignity, on equality and freedom. And I would also possibly add that it has to be justified based on scientific evidence that is available at our disposal. And of course, restrictions would also need to be proportional to the purpose of the limitation. And it is also clear that at times individual freedoms do come secondary to public good, and this itself must be considered. Next slide. If we were just to go back to the Disaster Management Act and to the Occupational Health and Safety Act, which is the sphere in which I operate mostly, the limitations that we've experienced during lockdown have been significant. Just to name a few, we all know that there are regulations that you need to follow if you enter public spaces, including the campus itself. There has been limitations to how funerals could be conducted. Indoor gatherings, movement of people has been limited during this pandemic. And the framework and criteria for management of the 2020 academic year in higher education institution has also outlined some of the limitations that we've had to implement as institutions of higher learning. And from an occupational health and safety point of view, there were specific measures that employers like UCT had to implement, and this includes limiting access to workplaces, ensuring that there's social distancing, provision of personal protective equipment, and so forth. Next slide. So UCT as a public institution, of course, as we will all agree, has got a duty to protect, to promote, and to fulfill the rights, the rights contained in the Bill of Rights. It needs to protect not only its staff, its students, but also visitors and contractors who are on site as well. It has to provide a safe working environment for us all. And of course, this is keeping in line or keeping in mind what the university's core mandate is. And that is the reason many of us are here, which is to get quality teaching and learning from our lecturers, to engage in research, and of course, to participate in social responsiveness as well. And to fulfill this mandate, the executive has been very clear that face-to-face and on-site learning remain a core component. And I would also possibly add that many of us as students as well will agree that the value of face-to-face and on-site communication or interaction with lecturers remains paramount and important as well. So just for those who are not aware, and I'll literally just whiz through this, just to be aware that there is an Occupational Health and Safety Directive from the Department of Employment and Labour. And this directive outlines what are some of the measures that employers need to have in place in order to protect its staff and its students or its visitors. It also outlines the interaction with many other acts as well, including the Labour Relations Act and the Employment Equity Act. What was also important, particularly in the June 21 directive, is that the directive allows for employers to have a mandatory vaccination policy. So for employers who choose to have a mandatory vaccination policy, there are principles that would need to be followed. One is that the policy needs to be fair, it needs to be transparent, and it needs to be accessible. And this meeting, part of it is exactly that, ensuring that your views, ensuring that your opinions around how such a policy could be drafted and implemented are important to ensure that the student body is clear that the policy will be fair, it will be transparent, and it will also be accessible. It is also important for the employer to ensure that there are opportunities to vaccinate easily and accessible, and that these are accessible. There are questions on the chat that what about those who come to the university as first years in the next academic year and only turn 18 at that point in time and only then are eligible for vaccination? One of the questions that will be raised, therefore, should be how does the institution ensure that there is accessibility of the vaccine as well? It also needs to make sure as an employer that you implement such a policy for justifiable reasons as well. And of course, that you balance the institutional staff members, because the directive is directed to employees, to balance the constitutional rights with those, or balance the constitutional rights as you implement such a policy as well. Other measures that need to be in place would include conducting risk assessments, which the university has done, and based on the risk assessments, develop health and safety policies or plans. It is important to take into account union agreements on a vaccination policy, to consider the Bill of Rights as I've described previously, and also ensure that you balance the overall good of the public, considering individual rights as well. So if we were now to move slightly away from the directive, now that you have an idea of what is contained in the directive and some of the requirements for an employer to have in place if considering to implement a vaccine mandate. From a student perspective, it is also clear that UCT has got a responsibility for both current and future students to ensure that the campus reopens safely. So plans, of course, are currently underway for the return of both undergraduate and postgraduate students onto campus. So undergraduate students, for example, would be expected to be in Cape Town and to attend campus from the start of 2020 academic year. And of course, regulations permitting to remain for the duration of the year on campus. Postgraduate students as well would be expected to have contact and face-to-face sessions, including access to campus as well. However, the pandemic will still be with us for a while, therefore blended learning will continue most likely for the next few months or years with both online and face-to-face experiences. The Higher Education Act enables universities as well to make rules requiring vaccination for access to campus and/or in-person activities. It also empowers the council of the institution to put measures in place to ensure the health and safety of students and staff on campus. Therefore, it is the university's duty to ensure that students living in residences or those who are coming onto campus are protected against COVID-19 infection. And of course, in instituting a mandatory vaccination policy, it has to take into account the Constitution and the legal prescripts as well. So just again to reiterate, only council can approve a mandatory vaccination policy, and it has to take into account stakeholder engagements and the input that has been provided. The executive, as the Vice Chancellor has said, for example, has also made its position very clear regarding mandatory vaccination. Senate has also put forth its recommendation, which I will read. And of course, the comments, the questions, and the contributions from students and from staff would also be included in that consideration. Next slide. So in terms of the Senate resolution, Senate did meet on the 17th of September, and it has resolved, and I'll just read some parts of the resolution because there seems to have been a bit of confusion as well from what has been said in the public domain, that the Senate recommends to Council that Council mandates the executive officers of the universities and Senate itself by no later than the 1st of November to constitute a panel of eminent domain specialists and members of the general staff and student bodies to primarily do two things. The first is to establish the logistical and operational features required to operate, to implement such a mandate. So issues around access to vaccination sites, communications to students and staff, etc. The second is establishing a systematic principles and rules and guidance regarding those who can be exempted from such a policy as well. I've seen in the chat those who've got medical reasons or constitutional objections to it. What would be the rules and the guidance regarding those who have or who would like to bring forth those opinions? It would be this group of eminent specialists that would be tasked with crafting a policy that takes into account these two key areas. Next slide. And UCT is not the only universities that has been thinking or mulling the prospect of vaccine mandate. Other institutions, our sister universities in the province and across the country, have also been considering these mandates as well. If we were to look internationally, both in the global north and global south, universities have also moved towards mandating vaccination as well. These are just some of the universities that I've selected, and I've had to go onto their website and actually check for what their vaccine mandate says, and I've just screenshotted some of what the requirements are on their sites or in their policies. And Harvard University, for example, if we could use that, indicates very clearly that the university is requiring COVID-19 vaccination for all Harvard community members, and this includes students, it includes faculty, it includes staff and researchers. And campus-wide vaccination is, of course, in the view of their university, a very key defense against the coronavirus. And in summary, UCT will continue with its voluntary vaccination policy. It will continue to promote campaigns of voluntary vaccination and will continue to have access to vaccination centers, to the Vaccination Center of Hope. And it will continue to facilitate access to the vaccination site. In thinking around the UCT mandatory vaccination policy, it is important to engage robustly with various stakeholders. And it is also important, particularly with us as students, for an agreement to be reached on the policy and the implementation process with our various student representatives. Once the policy is approved, of course, this will require council. It is also important for us to keep a vigilant eye on its implementation and ensuring that the logistical and operational features are required for this mandate are actually considered. So I close with the last picture that it is my hope that this discussion will allow us to consider the impact that COVID-19 vaccination, in addition to the non-pharmaceutical measures, can be used in order to help us all return to a new normal where quality teaching and learning, where research and where social responsiveness can again become the norm at UCT. Thank you, and over to you, Vice Chancellor.
Thank you very much, Dr. Ntatamala. And thank you to Dr. Shital Kasim as well. We will now take your questions. And obviously we don't have enough time, and there's lots of questions. We're going to take as many as we can. We are joined by 4 more colleagues who can discuss different aspects of the mandatory vaccination policy. Dr. Reno Mora is the Chief Operating Officer of UCT, and he can address questions about what mandatory vaccination will mean from an operational standpoint. We have Professor Linda Gale Becker, who's an infectious disease specialist and a co-investigator on the Sisonke COVID-19 vaccine trial, which involves close to 500,000 South African health workers. And she looked at the safety and impact on COVID variants, including the highly transmittable Delta variant. She brought the motion for mandatory COVID-19 vaccination to Senate last month. We have Emeritus Associate Professor David Kutsier, and he's a public health specialist who works in Dr. Mora's office on COVID-19 projects for UCT. And Dr. Tracy Naledi is the Deputy Dean of Health Services in the Faculty of Health Sciences with more than 20 years experience in government and the NGO sector. And so I'm going to read some of the questions. Let me start with this one that says, can we be allowed to demonstrate natural immunity instead of mandating vaccines, since we know that natural immunity is more robust and has a longer lasting effectiveness than the vaccines? Linda Gale, do you want to take that?
Happy to, VC. I just want to first say that I think the question is an important one, but just to rephrase it, I don't think there is strong scientific evidence that the immune response that is established after natural infection is better than the response we get after vaccination. So we are seeing breakthrough infections in both instances. And in fact, there is actually laboratory data to suggest that the T cell, so the second component of the immune system, is a stronger response after vaccination. So I would first ask the asker of that question to go back and look at the data, and I'm very happy to share data that supports what I've just said. The second would be, certainly there is a move around the world to say, if not vaccinated, then you have to produce evidence of previous infection alongside evidence that you are currently not infected. So it requires regular testing. And in some places, this is up to twice a week to ensure that you are not actually currently reinfected with the virus. So that's often how those two components go hand in hand. So really a second kind of approach, however, very laboratory intensive. And obviously there are costs involved with having to do regular testing in that way.
All right. The second question is also a bit longish. It says, is it not deeply unethical to mandate personal medical decisions? How do you justify this unconstitutional violation of free will and our right to choose what we do with our bodies? It feels deeply concerning for institutions to have the power to exclude those who do not wish to undergo this medical procedure from access to an education. Why not strongly encourage vaccination instead of mandating it, especially given that the proposed solution does not entirely eradicate transmission of the virus? Panelist, Reno?
I think it is important to talk about how the Constitution allows us to balance individual rights and rights for the public good. So it would not be seen as unconstitutional to balance those rights. The Constitution allows it. Section 36 of the Constitution permits such a balancing act. And just to clarify, the Human Rights Commission also, in its 4th of October 2021 statement, clarified its position that it is constitutionally permitted to mandate vaccination for the age groups that qualify for vaccination. And so I think our approach as an institution will always be to respect the Constitution, to respect the provisions of the balancing. And if you then transfer it to the issues of public health versus individual health, it is also balancing that we do things in the interest of the public good. And in some of those instances, it does infringe on individual rights. But it's not a matter of forcing people to do it. It's a matter of a considered opinion. And I think that's the way that we as an institution would want to see it. That's the way I think the Human Rights Commission sees it. And that's the way a number of experts in South Africa have posited and positioned the mandatory vaccination. So the key message, take-home message, that it is not unconstitutional. Secondly, UCT is wholly committed to upholding the values, the spirit, the principles of the Constitution and the Bill of Rights. and we will work within our constitutional and legislative mandate to balance public good with individual rights.
All right. There's people who are asking whether is it possible to have a free COVID-19 testing facilities for those who do not want to take the vaccine. That is every week or two, one goes to the testing center to get tested and access to UCT facilities. I want to join that question with the one that a few people have asked. Is it possible for one not to refuse vaccination on the basis of religious reasons? Reno?
Yeah, Vice Chancellor, I'll take the question on the issue of refusing vaccination based on constitutional and medical reasons. Certainly, the Constitution provides for that. Also, the directive that Itumeleng spoke to provides for that. And if you look at the Senate resolution in terms of the guidance that Council may consider, it is important to have a diverse and multidisciplinary committee that looks at these good and reasonable grounds for turning down vaccination, either on constitutional basis or medical basis. So yes, that will be considered, and we will make sure that all those things are fair and transparent in the implementation. Just to clarify as well, that we have not as yet implemented that panel. It is a recommendation that Council will need to deal with on Saturday. I'll hand over to other colleagues in the room on the vaccine question.
Yeah, I don't know if David wants to pick that up, but let me just say that obviously this is a nasal swab, investigation, which obviously for long periods of time may be exhaustive. On the other hand, also it is not without cost. So I'd leave it up to to the leadership to say whether UCT could fund that. I don't think that's happening anywhere else in the world. Even today, I can tell you in France, they have moved to a situation where if you choose not to be vaccinated, you do need to go for regular testing, and that testing is now needing to be paid for by the individual. So I think this is the way the world is sort of moving in that regard. I think also we have to consider that when and if we move into another wave, we know that there's enormous pressure on our testing services. And again, part of this to get vaccines up is to reduce pressure not only on hospitals, wards, ICUs, but also on testing services. We know that time for the turnaround takes a lot longer when we are in the midst of a surge, because there's just so much going through the lab and the turnaround becomes a lot more difficult. So I think all of these are considerations. Having said that, I could imagine, and as Reno says, we haven't constituted the panel, but for those individuals who cannot be vaccinated for medical reasons or for other reasons, this could be a way of managing them or helping them to stay on campus, but it would obviously be better to be the exception rather than the rule for the reasons of logistics, which I've already just tried to explain. And if David has any more, or Tracy for that matter.
I think I would agree with everything you've said. And I think and I've seen some of this discussion that's going on at WITS at the moment, because they've already put out their policy, and that it would just be totally impractical if we got another wave, because you need the testing to diagnose cases then, not to decide whether somebody's positive or not. And it would just totally overwhelm our services, and our hospitals wouldn't be able to function because they'd be getting the result back a week later when they need it, within 24 hours. So that has been the main discussion. And on the other two, you mentioned already the cost, and then the practicality of arranging all this will be very, very, very difficult. So I agree with everything you've said.
All right, the next question says, available evidence suggests vaccines offer protection against known variants, including the Delta variant, particularly against hospitalization and death. What is the association between increased transmissibility and protection?
when these vaccines were formulated, and I want to say vis-a-vis the last question, this is the beauty of vaccination. It's a shot in the arm and walk away. You don't have to do all the swabs up the nose and checking every regular. I mean, that is you were vaccinated as a child and you didn't have to think about smallpox or polio or measles again after that. This is the beauty of vaccination. When you get your yellow fever vaccination, you go into Central and West Africa not worrying that you might go down with yellow fever even if there are mosquitoes around. So just to say, that is actually the beauty of being able to do it. So when we designed these vaccines, they were designed to stop disease and death. And that's exactly why you get vaccinated as an individual. I don't want to end up in an ICU. I certainly don't want to be intubated, and I don't want to get long COVID because it is very disabling. So I do it for me. Now, the secondary bonus of these vaccines are that, number one, if I'm vaccinated, I'm less likely to become infected, and therefore I am less likely to be a transmitter of the virus when I am infected. If I do get breakthrough, because we already discussed it's not 100%, if I do get infected, which is less likely, I also have a shorter period of infectiousness. And it is when I am infectious that I can transmit virus again to other people. So the wonderful thing of a shortening of infectiousness is that I reduce the risk of transmitting to other people. All of this goes to say that if sufficient of us are vaccinated, we will get the knock-on effect amplified. And that amplification means across the board, the amount of virus being transmitted in our community, which will be the University of Cape Town campus, will reduce. And that's the added bonus that vaccination on a mass scale brings. There's no doubt that on an individual scale, you get benefit, but on a mass scale, we will get the secondary benefit of a reduction in transmission. And this, we were at pains to show you, is happening in the UK, it's happening in other institutions. Denmark has gone back to not having any restrictions at all. So that's what we're aiming for in the microcosm of our own campus. And it's a wonderful goal to try and reach out for.
I personally know 3 people who died within weeks after receiving the vaccine. One died within 2 hours after receiving the vaccine. They did not have some prior health condition, and even if they did, how many of us have something or other that is not perfect with our health? Another has to now have their leg amputated due to the visible blood clots that have formed after being vaccinated. These are facts of people I personally know, not some conspiracy. Any comment?
So I'd like to ask the individual if they have actually, if those individuals have reported these conditions and these cases, because we are carefully monitoring these kinds of adverse events. Certainly in Sosonke, 500 healthcare workers, 500,000, we have carefully monitored this potential, certainly within 28 days and 3 months after vaccination. So I have not, it has not come to my ears about these kinds of cases. And so I would really ask that if you have any influence on those individuals, that they do report them to the authorities. But this certainly is not what we have been hearing through our reporting methods. In addition, these are the same vaccines that are being given out in millions, multiple millions around the world. And again, this kind of event that you're describing has not been reported around the world. So either there is a mass, effort to stifle this sort of thing, which I honestly don't believe. Remembering WHO is also monitoring all of this. The World Health Organization, the CDC, our own SAPRA is monitoring this very carefully. I think that I would like to scrutinize those cases a little more carefully to understand whether they really were vaccine related.
All right, will I be rejected from studying at UCT if I'm not vaccinated?
Thanks, Vice Chancellor. I mean, the mandating policy will require that all staff and students to be registered need to be able, if it is approved, to provide proof of vaccination. There are obviously exceptions that we've mentioned, and one of them would be because young people under the age of 18 at the moment are not being vaccinated. Clearly, UCT would have to consider those exceptions. We would also have to consider the exceptions based on constitutional and medical grounds, but certainly from a mandating point of view, it will be a requirement to demonstrate proof of vaccination to be either a staff member or a student, a registered student, undergraduate or postgraduate.
Does it mean people will be fired if they are not vaccinated, or they'll simply not get the job, Reno?
The requirement that Itumeleng referred to, the June 2021 directive, is very clear that UCT as an employer needs to make sure that it follows all the prescripts of the law. We need to be able to reasonably accommodate people who are not able to be vaccinated for whatever reason. It is at the end of a process, like many incapacity processes currently under the Labour Relations Act, that someone at the end of the process, having gone through all of these and cannot be reasonably accommodated, that consideration does occur. But UCT as an employer would not willy-nilly fire anybody. I mean, that's just not being a good employer and an employer of choice. Not only that, the spirit and the nature of our institution is to make sure we do things properly and fairly. There is, yes, the possibility that at the end of the line, there may be that decision to be made, but it's certainly not one that one just takes willy-nilly. It's a considered decision and a considered approach.
All right. Are there any side effects to the vaccine? What are the side effects of the vaccine?
So yes, with any vaccine, like with any vaccine, immediately afterwards, we do expect a little bit of what we call reactogenicity. And that is side effects that can happen, and is a painful arm after the vaccine, sometimes having a little bit of a headache, sometimes a little bit of tiredness, feeling a little bit run down. But these side effects of the vaccine that are common last a few days, resolve completely. Like I mentioned in my presentation, there are very rare side effects that we have picked up, and because we've done the clinical trials and because we've done the rollout and we've vaccinated millions of people, so we will pick up some rare events. But in terms of side effects of the vaccination, I mean, I experienced a painful arm for 3 days and a little bit of a headache. I took some Panados and I was fine, and I think that's the most common experience people have.
Right. Costa, there are many questions. Let me go. Okay.
VC, I can quickly pick up the under 18 one. Just to give people the information that already SAHPRA, our regulator, has approved vaccines for adolescents. And NDOH is considering this at the moment. So I would imagine that by the start of the new year, this will be approved and in process by NDOH. So we imagine, again, this will be phased with a sort of 12 to 18 group going first, and then working the age down to children.
Okay. Will UCT claim liability for any short or long-term side effects or various adverse events, including death from the vaccines administered, Rena?
Thanks, Vice Chancellor. These questions of medical legal liability are really the most difficult ones to answer. And I think our approach is generally that there are so many medical interventions, including vaccination, that it's a difficult space to give an absolute answer. We won't be making any claims if that's the question, but certainly we would be concerned just as an institution on medical legal grounds, and really will follow all the necessary legal and other provisions required to address those. And so it is an area that needs to be debated and discussed. And as my understanding is, and some of the colleagues in the room will indicate it is also happening in many other countries around the world. The same issues are being considered, but certainly we will not be laying any claims to it and would need to carefully consider each case. David Kutsia may want to add to that as well.
Covered everything, thanks.
Okay, David, maybe you can take this one. Will we be able to return to normal teaching mode, that is full venue capacity, if everyone is vaccinated?
Sure. Well, what we want to do, we want to open the university as far as possible, but obviously we will still have to take precautions until we get to a stage where the majority, well, people are talking about 80% of people are vaccinated. We will still have to take all the precautions that we currently take. So in other words, social distancing, wearing of masks, but we should be able to open venues more and to increase capacity if that is allowed. Remember, we'll always have to do everything in accordance with the regulations, the lockdown regulations at the time. So we can't make our own regulations. We have to follow the government's lockdown regulations. So we would have vaccination plus those measures as well, but allowing us to increase density on campus and allowing us to open up much more to face-to-face learning and research.
All right. Is the COVID vaccine in line with the Nuremberg Code? I don't know what the Nuremberg.
I'm presuming that they mean the mandate, and I think that's getting at ethics, VC, and freedom of choice and freedom of will. So again, I think, you know, Dr. Naledi, Reno, everybody has been at pains. Itumeleng has made the point that this is not a forced, coercive instruction. This is not saying to somebody, we are going to hold you down and put a vaccine in your arm. We cannot do that. No, this would be totally unconstitutional. So that is not on the table. And we can, you know, go back and explain exactly what we are proposing, but I want to be clear that that is not what we are proposing, and therefore, no, we are not breaking any code, ethical or otherwise, in what we are suggesting. I see another comment that this isn't even happening in the US. I do again want to say, we need to update that information, that in fact a large number of universities and colleges in the US are in fact going this direction in order to get their students back onto campus. So we are not out of keeping with the rest of the world in exploring this opportunity.
Please address the false myths about the vaccine, such as it causes infertility, contains microchips, contains something that can allow the government to activate people, or that it shortens your life expectancy. Those who do not get the vaccine allow the virus to mutate in a larger population. In short, anti-vaxxers are allowing themselves to be a human petri dish for the virus. This person is asking that you elaborate on this. Reno, you want to start?
Vice Chancellor, I think Linda Gale is best suited for this one.
I'm thinking maybe it's too out there to even talk about it.
No, yeah, I think I'll defer to the experts on this one.
I think what I'd like to say is, you know, I think those myths do need to be bust entirely. They are extraordinarily wrong. We cannot, in the tip of a tiny needle, put a chip into anybody. Neither, you know, can I imagine why that would ever happen. That's the first thing. Secondly, it definitely does not have an impact on fertility. I've heard that testes shrink. I've heard that your, you know, menstrual cycle goes wonky. All of this is not related to the vaccine. So this has been constructed, you know, created. These are not truths. And it's important that we as an academic body, as students who are, you know, in the have the opportunity to be in places of learning, that we actually do look at good sources of information and get the correct information about this. And I agree, we have to, really spread the word to our friends wherever we have the opportunity to do that. I do, however, want to take the stance that it isn't helpful to then call names to those individuals who are maybe sitting on the fence and haven't quite made the decision to vaccinate. We don't want to alienate those people either. So I don't want to think about somebody as a human petri dish, in as much as maybe that person just has to make that decision for themselves, and we want to encourage them to make the right decision that has a good impact on their own lives. And here, of course, we are very much supporting that they have a vaccination, but maybe they have real concerns. And that's exactly what we're trying to do here today, is allay those concerns with good information. So, rather than call somebody a name, let's really encourage them to climb into the group of people who are vaccinated, rather than either sit on the fence or sit in the other camp.
All right. Bruno?
Thanks, Vice-Chancellor. I wanted to pick up on a few comments that Linda Gale made. I think us as a group and on the panel, we completely recognize that within our own community, the issue of vaccine hesitancy is a real one. And I think we must not simply, when these matters come up, label anyone. People have real concerns. Our responsibility is to be able to communicate clearly, provide the information in a format that everybody can understand, and not assume that there's a hidden agenda behind the hesitancy. And it really builds on what Linda Gale is speaking about. And I think across the world, people are trying to translate sometimes complex information into easily understandable information, because it's our duty to care so that people know in this vaccine discussion, in the vaccine mandate, what the real facts and issues are. So we do welcome the questions and certainly recognize that vaccine hesitancy is a real issue within our South African population across our country.
All right. The issue of not knowing the long-term effects of the vaccine is what is causing hesitancy. Usually clinical trials take years to complete, because observations are ongoing. So with the COVID vaccine, everything seems so rushed. Shita?
I'm glad this question was asked, because I saw another question in the chat about why did we rush the process of these COVID vaccines? And I want to be clear in saying, I also presented this in my slide, that we have an existing platform of vaccine technology that we know. The vaccines were developed based on this platform. So we've been studying vaccines for years and years and years, and these technologies are not brand new. The other thing is that the process was not rushed. Clinical trials occur in phases, and with COVID-19 vaccines, there was a multinational, a global effort and global funding actually even to get these vaccine trials underway. So that's one point where sometimes with vaccines, we sit and we wait for funding, and we wait for things like who's going to develop the vaccine. And through this, we managed to efficiently maximize the process of clinical trials. There were no skipped steps in the process of developing and getting these vaccines out. I want that to be very clear. The clinical trials were robust. Having worked on the clinical trials myself, I can attest to that. They were robust. We managed the data. We looked at side effects. We looked at a lot of things and efficacy. And I think Prof. Becker can also attest to that there were no skipped steps in the vaccine process. I don't know if Prof. Becker.
You want to add, Linda Gale?
Yeah, I want to add just around the long-term effects, and I think the questioner is absolutely right. The fact of the matter is we've only had SARS-CoV-2 for 18-19 months, so we are learning in terms of this epidemic. It's a new pathogen, so every day we have more experience, and I think Sheetal alluded to this. We're having, if anything, actually information overload, because every day there is new information coming out about you know, the way we're going and where we are. However, vaccines is a very, very old concept. There is nothing new in terms of recency around vaccination per se. And we have good long-term histories and information about long-term impact of vaccine. And certainly there is no evidence that, you know, if you get a vaccine as a child, you are going to have problems in your old age. If, in fact, on the contrary, you are likely in Africa to live longer if you get vaccination. It's the kids who don't get vaccinated who are at risk of early death, early morbidity, disease and problems. So actually, the platform is a very sound one for making sure that we don't have long-term impacts down the road. And one of the ways, you know, I think people sort of have this notion that this thing is sitting in your body as a lump for a long time. It isn't. It is and I've heard the best analogy I've heard is this, because I don't even know this platform, so I'm going to appeal to each of you. It's like Snapchat. You send the message goes in via needle, it passes the message on to your immune system, which you already have, and then it disappears, much like Snapchat does. It's gone. It's left the message and it's gone. That's exactly the benefit and the beauty of vaccination. And this is why, you know, we don't expect long-term impacts down the road. And as I say, history certainly has supported that to date. So whilst I can't tell you, obviously, because I don't have a crystal ball, that COVID is not going to be in some way completely exceptional in this regard, I feel very reassured that there is no reason to think that COVID-19 is going to behave differently to other vaccinations that we've had for time immemorial.
All right. Tracy?
I just also want to add to the conversation and say that part of the reason that we actually don't have time to wait is the impact. We've already touched a little bit on the impact on the health system. And now those of us who work in the health system, those of us that use the health system know that, number one, the health system, even before COVID, was already thinly stretched. So what has happened with COVID is that it has displaced the other burdens of disease, you know, so we are not able to screen and give treatment early for some of the chronic conditions. So there's a lot of burden of disease that is out there in the community that's suffering, number one. And we are going to feel the impact of this in the next 2 to 3 years, 5 years, when we are now having consequences of this. Number two, right now, we, and Sheetal showed this, over 260,000 additional deaths. So this is on top of just the average deaths that we have in South Africa. That's 1 in 4 deaths. That is an additional death that would not have been there. That's linked directly or indirectly to COVID. And thirdly, it's about the economy. You know, we have lost, I think, 8% of our GDP. People have lost jobs, etc. And for me, what is disheartening about that is that, you know, high-income countries have had the same impact on them, but they will recover. By 2022, 90% of them would have recovered. Whereas for us, low-income countries, what the World Bank estimates is that only 1/3 of low-income countries are going to be able to recover from it. And so it's going to deepen inequality, deepen poverty. So we actually don't have the time to wait and see if this works. And what my colleagues have said is that we have enough evidence to say that the benefit of doing this far outweighs the risks. Yes, there are risks, but when we have to balance and do the very best for the most people, this is the best that we have at our disposal, and we do not have the time to wait for something that's even better. And as Sheetal said, what we do have is actually quite good.
I think this is a good question to follow up on. John says, I'm 24, male, metabolically healthy, exercises 5 to 7 times a week and gets sunlight. Show me the stats on someone of this demographic dying from COVID. It would be so statistically rare as to not be worth my concern. I do not feel comfortable taking this novel drug. when I have already fortified my own immunity to the best of my ability and knowledge. If by some statistical perverse fluke I die from COVID, then so be it. After such circumstance, I submit it would be morally wrong to deny me the opportunity to finish my MA next year by barring me from campus. I think there are many young students who are saying this. Response, Linda Gay?
Yeah, and John, congratulations. I mean, I'm delighted, and you've been reading the literature as well. So yes, vitamin D and sunlight are all, you know, good ways to go. So I totally agree with you. The chances of you dying of COVID are tiny. You know, you, however, are at great risk of getting infection. And the reason is because you are young and social, and you know, like to, I presume, go, you know, get into the classroom at the very least, but certainly get into social circumstances where you are going to be exposed to virus and you will become infected. Now, you may be asymptomatically infected, you may be mildly infected, you may go down with long COVID. So you've got to think about that. That doesn't seem to be something that is in any way linked to previous comorbidity. But let's say you just get mild infection. The problem is that you then become somebody who can bring that viral load onto campus and in turn transmit the virus to other people. And that is what when we're considering this now on our campus, we are really looking for the secondary benefit of mass vaccination. And as Sheetal showed so beautifully in the diagrams, if too many people decide that they are exceptions and need to step back, which may happen if we rely entirely on voluntary and people stepping up, if there are too many exceptions, the virus will exploit those gaps and we won't get the secondary value of a solidified immune response and protection. So that is really where we are going with this, that yes, the benefit for you as an individual against severe disease and death is less tangible, less obvious, but the benefit we as a community will derive, and this is Ubuntu, it is absolutely founded on the principles of I am because we are. If I take on this vaccine, then I contribute to the overall protection of my community. And this is what we are asking you to think about doing as a viable member of our community. And like you, we absolutely want you to get your master's to succeed and get on with your life. That is really where we are positioning ourselves today.
And then someone said, while I understand the thought behind UCT having a conditional vaccine policy, as a student who is thoroughly enjoying their education at UCT and has a so-called anti-vax approach, it puts me in a rather difficult position. Fiscally, we know it does not infringe on any laws. However, from a humanitarian perspective, I must confess that it feels rather targeted towards those who would prefer not to have potentially harmful proteins shot into their system. The way I look at it is that there is no harm done by those of us who choose not to get vaccinated for ourselves, not those who choose to be anti-vax and push it onto others. That is a rather different situation, but those who did it purely for individual reasons, be it cultural, spiritual, physical, or any other aspect. On the opposing side, for UCT to enact this policy is forceful in its nature. Do it our way or you may not attend our university. It is not illegal, it is not politically incorrect. But to refuse even a fraction of your students to attend your institution because of your somewhat radical beliefs is rather blinded. It's a rather blinded approach and all sounds a bit familiar, does it not? My stand is that UCT should allow their students to make this powerful choice without an ultimatum, weighted with educational politics. Integration back into the normal space of life is beginning to happen thanks to the vaccine, but forcing people in essence to receive the vaccine in order to return to normal life will result in a community that is integrated yet void of empathy and left with a bitter taste of resentment. I vote no. Itumele?
Thanks, Vice Chancellor, and thanks for the comment and the concerns that were raised. I think one of the first things that we possibly have to discuss as well is the notion of a forced vaccine. My colleagues on the panel, and I think Rino as well, has indicated that the policy that is being proposed is in no way to force individuals to take the vaccine. Part of what the policy is saying is if there are reasons for not wanting to take the vaccine or being unable to take the vaccine, be it on constitutional grounds or on medical grounds, those would have to be considered as well. And part of what senators proposed is that this committee of experts, part of what will be needed is making sure that the guidelines are there to ensure, as the comment or as the student is saying, that there are empathic and ethical ways in which those type of concerns are addressed as well. Yeah, so for me, the question around being forced must be addressed, and we must also make it clear that there is a policy that mandates the vaccination, and it is based on scientific evidence. And I think we've been at pains to explain the benefits that not only will accrue to the individual, but to the community as well, but also understanding that the public benefit will possibly be much more for the whole institution than for individuals as well. So that's just in terms of addressing that issue around the forced nature of the vaccines. Thank you.
If people develop COVID antibodies from natural acquired immunity, does this also aid in establishing herd immunity?
Yeah, I'll quickly answer that to say yes, in as much as immunity against SARS-CoV-2 of any shape or form is good. It all contributes to building those hedges. So there is no doubt that, you know, the good news, I suppose, is that we've gone through 3 waves, and so increasingly more and more people in South Africa are not completely what we call naive, which means they have fresh, virginal immune systems that have never seen SARS-CoV-2, because that is the most dangerous. The virus, you know, can have a free-for-all if it meets no resistance from your immune system at all. Natural immunity provides some, but as Sheetal showed you on her slides, that is not foolproof. And we definitely have evidence that people who have had previous infection have been reinfected with Delta. They were reinfected with Beta. I know, you know, some people have had literally 3 doses of the virus. So it is not like vaccine. It is not foolproof. However, and I will say this again, I think there is good laboratory-based data to show that with vaccination, you get better depth and better breadth of the immune response. So that's just the richness of your immune response is better with vaccination. If you add the 2 together, you really get a double bonus. So you get both, you know, the value of the infection in its first right, and then you get the wonderful bonus of a boost with the vaccination, or vice versa. You do it the other way around. Again, this is all good for building immunity. So the reason we don't say, and that was why it was so controversial to just say we need herd immunity, the cost of people going down with disease and dying is a huge cost to say, all right, well, let's just let people get infected and then we'll see who survives on the other side. And, you know, that'll be terrific. Well, you know, we're a civilized country. We're a civilized community. We can't allow that to happen without trying to save their lives in ICU, without mourning the death of those people, usually the older people in our community. So this again is where vaccination steps in to say we can get herd immunity without the cost of people potentially getting a bad dose of the disease and potentially dying.
Okay, so there's a question about the fact that at Harvard they instituted, are you aware Harvard Business School instituted a mandate such that 95% of students and staff were vaccinated, and they nevertheless experienced a severe outbreak, causing them to revert back to online learning? I guess it's a similar question to the Israel question. Anyone wants to answer it? Linda Gale, can you?
Yeah, so and I saw the question around the UK. So I think the fact is none of us are in any way, promising that if we get vaccinated, you're never going to get disease again, and the whole thing will eliminate the disease. Unfortunately, probably SARS-CoV-2 is with us for a long time to come. What we are trying to do is minimize the risk and try to get to a place where the viral infection prevalence is so low that actually we can get back to meetings, back to work, back to where we need to go. If that coverage is not sufficient, if we have not got enough people vaccinated sufficiently so that they've actually had time to build their immunity and become fully protected, then there are gaps and the virus will find those gaps. So this is people quote Israel all the time, yet the vaccination coverage in Israel today is sitting at 60%. Experts will tell you that is insufficient. Your 2/3, 1/3 is still too much gap for the virus to come in and have an impact. And as Sheetal showed, even if you are vaccinated, if the viral load coming in, the force of infection is so high because not enough people are vaccinated, your immune system could very well be overcome, and then you can have breakthroughs as a result. I think we have got other good evidence to show in countries now where there has been sufficient coverage and people have had time to get their full protection. We know it takes, a couple of weeks and in the case of J&J, it's actually a month before you are fully protected. Up until that time, there is the risk of ongoing infection and potential breakthroughs. So again, this isn't the end of the story. We are building this story to get us to a place where we can get back to work and get on with our lives.
If I've been vaccinated with Sinovac in another country, will this still be valid and recognized if a mandatory vaccine policy is passed?
Yeah, I mean, I would argue that, and obviously the nuts and bolts have to be, and David can speak to this, I'm sure, have to be worked out for our policy down the pike once we have, a clear way forward. But I certainly, as a clinician and a scientist, I would say there is no reason why we would not accept other vaccines where proof is given. And where, they are mainstream WHO line listed vaccines. And certainly Sinovac is one of those. It's a very good vaccine. It's being considered by SAHPRA at the moment. There actually is a trial going on in our children in South Africa at the moment with Sinovac. So, these and other line listed vaccines, I'm sure, will be considered where the individual can show, much as we do when we go overseas or we travel. We are going to have to show our QRS codes, our vaccine passports. That is a fact. You are going to have to do that in order to travel to other countries. So, that it's going to be a similar kind of principle.
All right. If UCT can get away with mandating this, what else can they get away with? Reno, perhaps.
Thanks, Vice Chancellor. I mean, the spirit of this conversation is coming to staff and students, and there's nothing surreptitious about it. We are not trying to do anything that is not either constitutional or not legal, or not in the spirit of caring for a community that is so wide and diverse. I think I've said on many occasions that the duty of care is about a social compact of all the members of our diverse community, and we have a responsibility to actually enact that duty of care and to do it in a very clear, fair, and transparent way. So the spirit in which we've come into this process is about protection, caring, and ensuring that we have a community that's safe and as safe as possible. And the whole conversation so far, even the vaccines that we consider to be safe, we need to respect the regulatory process. When there's a tick, then we accept that that is a due diligence has been done. And that's my sentiment, I think. It's a duty of care, and we do care to do it properly.
Thanks, Reno. I think that question made me sad, like where would we trust? Linda Gill, you might help us with this. So as a concern, can UCT ensure and guarantee that the vaccine is not gene therapy or is not going to change the human DNA or genome?
Absolutely, categorically can reassure that there is no way that a vaccine will do that. The virus does that. I'm going to say, this is exactly how a virus offloads, right? So it comes in, it goes via your ACE2 receptor, which many of your cells have. It docks on there, and it literally infuses its genetic material into the genetic material of your cells. It does that because it doesn't have its own machinery. It travels light. It's a virus. When it gets inside your cells, it uses your machinery. Be indignant. It uses your machinery to replicate that cell. And then that genotype, it then organizes its proteins around itself, and it buds out of your cells, and it then is ready to go out of your nose or out of your breath and infect another person. So the virus does it, the vaccine does not. The vaccine tells your immune system to get itself organized. So it says, here I am, I'm pretending to be the virus. I'm pretending I am not the virus. I'm pretending I look like the virus a little bit. I look like the virus's most inflammatory aspect, so that the immune system says, Hawkeye, I better organize myself. I've got to get my antibodies right. I've got to get my T cells right. It does not get into your genetic material, the vaccine. I can promise you that.
Yeah, I'm choosing questions that I think most students, they seem popular, sort of, they might be whatever. So I'm going to take last two. So one is, would this policy change if an alternative treatment was accepted? Dare I mention ivermectin? Although the bureaucrats currently do not accept the literature on the efficacy of ivermectin, currently 78 peer-reviewed studies. As far as I'm aware, there are more ongoing studies on the effectiveness of ivermectin as a prophylaxis and treatment for COVID-19. If we did find that such an alternative was as effective as vaccine, would we change this policy? Linda Gale, you're shaking your head.
Yeah, I mean, sadly, the question has arisen around ivermectin, which may be a very bad example, because what I can tell you now is that if you knew what the ingredients of the ivermectin was, you would be far more concerned than the ingredients inside a vaccine. So that's the first principle, is this is not an innocuous agent. It is a pharmaceutical. So that's the first thing. Secondly, I really beg to differ about the body of evidence. In fact, today I know of at least 4 large trials that have been retracted because of fraudulent information that was garnered during clinical trial development of ivermectin. And, you know, journals, very high-ranked journals, have had to publish retractions because it's been discovered that this information is really not it's made up. I mean, it's that bad. It's been actually fraudulently conjured. So the body of evidence for ivermectin at this moment is on extremely shaky ground. I will say to you that I try to keep an open mind. 3-4 months ago, I was still scouring the literature. I had an equipoised kind of approach to ivermectin. Maybe there's something in this. That has been completely dispelled in the last couple of months with evidence that not only have people, you know, fraudulently try to create a story, but actually there is just no body of evidence to support ivermectin. I'm afraid ivermectin, to my mind, is dead in the water. Now, there are other drugs that have come about more recently. Certainly monoclonal antibodies would be one. Those are licensed. And there are new there is a new antiviral that has actually just been shown to have a very good effect. So that, I think, remains a second line of defense for us. Our mothers taught us prevention is better than cure, right? So if we can prevent, it's always better. But it is good to have up our sleeve when somebody either didn't get vaccinated or they didn't have good vaccine take, or they have a breakthrough infection, that we can offer early treatment to try and reduce the impact of that virus for disease and death. So this is not an either or. I think we do want to keep treatment, but you don't know. I've had friends who within days of getting their COVID have ended up in hospital, in an ICU, very ill indeed. So, you may not have the luxury of time. In addition, these drugs aren't cheap. Monoclonal antibodies, it's going to take us a long time as a country to be able to afford that and be able to administer that. So again, I don't think it's an either or. I think we aren't throwing out vaccines at all in terms of our preventive measure, and we certainly will continue to look for good therapies in order to treat those who either have breakthrough infection or, for whatever reason, miss vaccination for some reason.
All right, last question. Why are we not waiting for national government as if this policy were to go to court? Because if this policy were to go to court, it could set back the university vaccine rollout even more. Itumeleng?
Just perhaps the student could give a bit more detail. So my understanding of national government is that the Department of Employment and Labour forms part of national government itself. So its consolidated direction on occupational health and safety does very explicitly, as I indicated in my slide, indicate on what condition, on what grounds can employers consider the vaccine mandates, and also Annex C, in fact, outlines step by step what needs to be in place in order for such a mandate to be considered. So on that basis, national government through the Department of Employment and Labour has considered it and has placed that on the table. And of course, before a direction like that is even promulgated, it has to go through numerous consultations with business, with labour, with ordinary citizens as well. So yeah, thanks.
Thank you very much, Itumeleng. So some students have asked whether we can make the presentations available. Shital, Itumeleng, I'm sure we can make them available. Some people want access to them. So those presentations will be available for those of you who want to have them. And then the one question, a few people have asked questions about first-year students. Does it mean they cannot come, they cannot apply to UCT if they're not vaccinated? And what about international students who are in countries that are not making vaccination available as easily as we're doing in South Africa? So here's the thing, students should apply to UCT if they are accepted. As you know, we have the Community of Hope vaccination center, so students will get vaccinated there. We will surely not put a student in residence or in a class or in the library if they are not vaccinated, but they can come in and they will they can get vaccinated at a Community of Hope. So that's what it is. So student, it doesn't mean we are closing out poor students from areas where there is no vaccination. So just so all the students who are in the room. Let me thank colleagues who are on the panel. Linda Gale, thank you very much. Shital, Itumeleng, Reno, David, and Tracy, thank you so much for sharing your knowledge, your expertise, and answering all the questions that have been asked. I'm sure students will continue to have questions, and please feel free to send them. We would like to hear from you, and please don't forget to complete the survey that is available for you to express your views. We'll close on Thursday at 6 o'clock, and we want to be able to present to council on Saturday. Let me thank the Communications and Marketing Department for organizing and managing this event, as well as our colleagues in ICTS for their expertise in managing the technical details behind the scenes. if I realized that there were a little less than 700 students, people on the call, please spread the message to your friends and colleagues to complete the survey. You can take the link and let them complete it so that we can have all your responses. We want to consider them. And if you have not been vaccinated yet, I encourage you to do so. You know, as we've been saying, it will help keep down the rate and severity of COVID-19. You and the members of the general public are welcome to visit our Community of Hope Vaccination Center at Forest Hill Residence. Just go there. There are no queues. Get vaccinated. We are open from Monday to Friday, 8 a.m. to 3 o'clock in the afternoon. Thank you very much, colleagues. Enjoy the rest of the day.